Good afternoon, everyone, and welcome to Let's Talk Dementia. I'm Sharon Jaguar, and I'm the Manager of Community Relations and Marketing for Visiting Nurse and Hospice for Vermont and New Hampshire. And today we have three panelists to talk about caregiving for someone with dementia. We have Mick Byers from Terrace, Premier Assisted Living and Memory Care. Mick Byers has been a nurse with an emphasis in dementia care for over 20 years. For the last 8 years, he has managed the care of the dementia community at Terrace Assisted Living. Mick incorporates the philosophy and strategies of care from the Best Friends approach to care led by Virginia Bell and David Troxel, and Person-Centered Dementia Care, a habilitation therapy training developed by the Alzheimer's Association. He was also trained through an in-service conference hosted by Positive Approach to Care, an organization founded by Teepa Snow, MSOTR/L, FAOTA. This is an organization that is dedicated to enhancing the life and relationships of those living with dementia. Mick and his wife are now in the process of creating a non-medical home care business that only treats those with a diagnosis of dementia with behavioral disturbances. They plan to begin taking on clients in March of 2021. Next, we have Amanda Fay. She is an MSN RN at Visiting Nurse and Hospice for Vermont and New Hampshire. Amanda is the Manager of Clinical Education and Evidence-Based Practice at Visiting Nurse and Hospice for Vermont and New Hampshire. She is a nurse educator that specializes in transformational learning for medical professionals and everyday people. Her love of nursing and education started at the same time, 20 years ago. She hasn't stopped practicing or teaching since. During her career, Amanda has specialized in many different areas, and one of them is dementia care. Lastly, we have Dr. Barbara Lazar. She is the medical director at Bayada Home Health, and she is also a physician on DHMC's community geriatrics team. She sees patients in their homes and at Cedar Hill Continuing Care Community in Windsor, Vermont. Welcome, everybody.
Thank you.
Thank you.
So we'll start with our first question today. And this question is for Dr. Lazar. What is the general trajectory of the disease? Is it always terminal? And is there a time for hospice?
Thank you so much for inviting me to be part of this panel. In terms of the trajectory of the disease, it varies tremendously. There are many, many different types of dementia, and they follow different paths depending on the underlying diagnosis. But in general, dementia is an umbrella term that we use for, several, maybe a dozen different types of dementia. There's many, many more subtle ones, but there's, 8 or 10 basic ones. And the trajectory for those illnesses generally is a slowly progressive arc of decline lasting years. Generally, I'd say 10 years would not be an unusual term of illness for this. People are diagnosed often when they're already fairly far into the process of dementia. And so depending on the time of diagnosis, the illness can last anywhere from 10 to 12 years. Certain types of dementia go in a more stepwise process, but generally it's a slow, steady arc of decline for most of our friends who have dementia. And I'm sorry, the second half of the question was what?
Is it always terminal? And is there a time for hospice?
Okay, so dementia itself certainly is a chronic illness that leads to death. I don't really use the term terminal very often when I talk to people with dementia, except for when people are clearly in the end stages of their life. Most people with dementia, as I think your listeners will know, are in their 70s to 80s, and so often have many comorbid conditions like heart disease or cancer or other things that might actually lead to their demise. But the dementia kind of sits with those other medical problems and makes life more challenging for most. And there's absolutely a time for hospice in the sense of promoting value, comfort, dignity in the final 6 months of people's lives. And I've been doing this work a long time, and I feel that hospice care is an absolutely essential part to the end of life for somebody with dementia.
Thank you, Dr. Lazar.
Sure.
Mick or Amanda, do you have any additional insights?
Just that as a manager of a community, I've always been one to always mention hospice before we get to that point where they need hospice, so the family is already aware that that's coming down the road and it's not going to be a shock to their system, and you don't have to deal with the stigmas that go along with being on hospice.
Amanda, you have any additional insight?
Just to build on what Mick and Dr. Lazar what they've already addressed, having that hospice conversation a little earlier will help the family make that additional transition, because they've already had to make a transition from where their loved one was when they met them and as they progressed on their life's journey. And now it's a different phase. And so having that hospice care enter in, it will help that caregiver make that additional transition and help their loved one make that transition as well.
Thank you. So, Dr. Lazar, what are some of the common medical complications seen with dementia as it progresses?
Well, it's an interesting question, because if we really lived in a world where people with dementia got the understanding, compassionate care that they need, and I don't mean just in facilities, I mean in the world, that if we could honestly understand this illness as in the early stages as a disability that requires accommodation, rather than this horrible, oh my gosh, you're at the end of your life, I think many, many people with dementia could live a very much different kind of life for a long time after diagnosis. And so that's something that I think is important for all of us to remember, that when our loved one is diagnosed with dementia, it's not really the beginning of the end that everybody talks about and fears and has so much heartbreak around. It's a chronic illness that comes for, I'd say, 40% of people over the age of 80.
Yeah.
And so when we're thinking about a new diagnosis and how the next 8, 10, 12 years is going to look, it has everything to do with how we as medical providers, nurses, support people in the community, family members, approach the person. And I just think that the trajectory of illness has everything to do with how we handle it, how we, the non-patient, handles it, and not heaping on disability to people who actually are still doing pretty well. So that was one point I wanted to make sure to make. I think that there certainly is a period in the illness, generally in the moderate stage, where there are all kinds of things that crop up. And as Mick had talked about a few of the techniques and trainings that he has had, again, the caregiver approach and the way those situations are handled have everything to do with how well or how poorly the person may do. So as a loved one of somebody with dementia, to understand that there's lots of resources and lots of ways of treating what goes on for your loved one that don't involve medication, that don't involve restrictions that we're commonly in the medical model. Unfortunately, if the only tool you have is a hammer, everything's going to look like a nail, right? So we're just really trying, I think, to help the universe understand that people with dementia are, in fact, people, and they're not a disease. And so what we need to do is understand from behind that patient's eyes what's happening. You know, are they confused? Are they tired? Are they hungry? Can they hear or see? Are there other issues going on that compound the trajectory of illness? And so really being a good detective and understanding how to address what you can address, you know, it's really, really crucial, and not just to chalk everything up to, oh, the dementia. And there's a number of ways that caregivers and loved ones can kind of meet the patient where they're at, and therefore lower anxiety, lower that distress that's very palpable when one of us is struggling with memory and communication. I'll stop talking. Sorry, I don't mean to go on and on.
Oh, that's fine. Amanda, building off of that, how can caregivers help prevent some of these complications or have better awareness around early detection?
Well, I think that Dr. Lazar really captured it. Like, it's that person-centered care, and the caregiver, they know this person intimately, and if we can help them really see the person where they're at, and try not to think about, Bob, when Bob was, he could solve, a complex math problem in his head, in under 30 seconds, or he could like bring up trivia at a drop of a hat. So having them see them where they're at, and really be those detectives. I loved that phrase, Dr. Lazar, how you said, really using those detective skills in understanding the person, so they can watch how they're eating. Is this, do they still like these foods? Can we, hedge off, or like really like stave off the dehydration that often goes along with, individuals who forget, sometimes they don't remember to drink, and so watching them and having them be that intimate partner, but in a different way.
Mick, any additional thoughts?
No, I think they captured it very well. I have a lot of respect for Dr. Lazar and her philosophy of dementia care, because it fits right along with what we're doing. I just can't say any more than what you've already filled in there.
Wonderful. So this next question is for you, Mick. How does one combat caregiver fatigue given the longevity of the disease?
Yeah, that's a good question. Caregiving is hard. It's very hard. And it's especially hard if you have not volunteered for that role. If you've been thrown into a position where you have that role, the stress level is even higher. So I will just say the core value of being a caregiver is what you want to hold on to, and that's to make sure that your loved one is safe, comfortable, and still having fun. If you can achieve those three goals, then you have great success with that. Along with that, though, I'm going to throw a few tips out, and the first being, don't take yourself seriously. Use humor, use laughter, and I'm talking about in your interactions with your loved one. That diffuses a lot of things by just being able to laugh at yourself. And along that same line, have empathy for your loved one and for yourself. This is not their fault. No matter what stage of that dementia they're in and what behaviors they're seeing, it is not their fault. It's the disease that has captured them. And the same is true for you as a caregiver. Give yourself a break, because this is not your fault either. This is just circumstances that landed you and your loved one here. So mistakes are going to be made along the way, whether professional or a family caregiver. You're going to make mistakes, and the power is in being able to just move past it. Go, I screwed up, but we'll just go forward from there. Much of the caregiver's stress, I will say, comes from a battle of wills. And if you understand that, the only thing that you need to worry about is making sure they're safe, comfortable, and having fun, then a lot of these peripheral things you can learn to let go of. For instance, if they were to grab a box of Kleenex and pull out one tissue after another, that's not something to get upset over. That's just them having a sensory issue. And so find those little battles that you find yourself going, and just go, okay, they're having fun with the tissue. So, all right. And just not allow that to be a part of your stress. Another big thing that's really important for the caregivers at home is that they need to socialize on a regular basis. That the instinct is to, when you're in the home with your loved one, is to block out the rest of the world and just let it be you and them. And that's not healthy. you need to have that support system for yourself, even if it's just your neighbor or your family coming over and having a cup of tea with you. Just find some way to socialize on a regular basis. And then the thing that every doctor will tell you is eat well, sleep right, exercise, take care of yourself, and have those regular family doctor checkups too, which you avoid when you're in that role. So those are all really important things. And the bottom line of all of that is you need to find your own spiritual center. My own happens to be mystic Christianity, but you could be Buddhist, you could be Hindu, whatever you find as your center. Hold on to that, explore that, because that's where you're going to find a lot of the peace of mind when you're in the midst of this stressful situation. That's all I got.
Amanda or Dr. Lazar, do you have any additional thoughts on how to combat caregiver fatigue?
I think mindfulness is a great piece that, because like Mick was talking about, kind of being in that moment, and sometimes having that moment for yourself, if you're able, take those little retreats in the bathroom if you can. Have just a moment of breath and take some nice deep breaths, because as a caregiver, you're changing too, and giving yourself that compassion and space to allow that change. There's Alzheimer's Association. It falls under that umbrella, but they do have some great supports. So if you're a caregiver who is tech savvy, or you're all into that teeny computer that you carry around in your pocket, check out the Alzheimer's Association. They have some great chat rooms and support networks, and it's a great resource.
Dr. Lazar?
I agree with everything that Amanda and Mick have said, and I also I just think it's important that caregivers remember that their person isn't just the disease. Their person is still their person. And there's still lots of ways that a person with dementia can express love and affection and open-heartedness and warmth. And I think just not prematurely closing the door that he's gone or she's not in there, because you'll be surprised if you're open to it. There's all kinds of ways the person will demonstrate that they are still in there, and that not to understate that deep feeling of grief that you have when your loved one has dementia, but just to remember that they're still there, and that there's really still human connectedness to have. The other resource that exists in our area is the Aging Resource Center at Dartmouth-Hitchcock. They really have some nice caregiver programs and a big lending library and workshops, and so that's something that folks might find helpful. But I agree with everything Mick and Amanda were saying around, giving yourself space and time to be whole, because your loved one will feel that immediately if you're not on your own center.
Wonderful. So this question's for you, Mick. My loved one was just diagnosed with dementia. Does that mean that they have to go to a nursing home? What would it look like if I wish to care for them at home?
Okay. So learning about the diagnosis early and acting on it early will save you a lot of heartache. So let's say you get that diagnosis in the early stages of dementia. You want to right away get your friends and family involved and be open about the diagnosis rather than giving into the stigma that something is really, really wrong. If you get ahead of it and let the family know ahead of it before you're even dealing with the day-to-day caregiving, that you're going to need support down the road, and then have them help you with being accountable for your own care and for the care of your loved one. Sometimes, as Dr. Lazar will tell you, sometimes the journey of dementia takes over 10 years. So this is a marathon, it's not a sprint. And so you want to explore in the early days what it means to have a home health agency, what it means to be a part of assisted living or a nursing home, and just find out, early, and have your loved one. I would recommend have your loved one be a part of that decision making with you, so that you'll have some clear choices before things do get emotional, and then you have to, from an emotional place, make these decisions, which it's never as healthy as just being pragmatic. I will say, and I can't stress it enough, you should never, ever, ever vow to your loved one that you will never put them in a nursing home, because you don't know what the future lies for any of you. And sometimes the nursing home is the best solution for your family. So I guess that's what I would say is, at the very beginning, just start making those plans early.
Amanda, Dr. Lazar, any additional thoughts?
Sorry.
Oh, no, you're good.
I'm so sorry. What I would suggest just has a lot to do with what Mick is saying. I think of it as like a hub and spokes. So like if you at home are the hub, then you're going to need some spokes to make your wheel go around. And so those spokes might be a neighbor or a cousin or a niece or a teenager who needs after school work. Like there's lots of ways to get some support. And I think in our society, we tend to be so closed to external help, right? It's me and mine, and we're going to take care of what's ours. I think this is a disease that really benefits from, it takes a village kind of mindset where we understand that this is a long haul, as we were saying. And if you can put a little bit of help in place, then that can preserve your ability as a caregiver to keep a loved one at home, if that's what you desire doing, because you're less fried, for a long time. And the people that I think we all have seen have more trouble are the people who are trying to hold it all on their own shoulders, and all of a sudden something, an illness or catastrophe for the caregiver themselves, or simply exhaustion, physical and emotional exhaustion, leads to placement in a nursing home, where if that's not the desired outcome, that could be prolonged or prevented with that kind of support around the edges earlier on. Sorry, Amanda, you go ahead.
Oh, no, because that's a great image, because it really is the caregivers, the hub, and then there are definitely spokes. I was just thinking about, so in those early stages, how to look at, before that, decisions made for different living situations. What about looking at your environment differently? Because with a chronic disease, you think about what are the tools that you need to be able to manage your disease. So how can you change your current environment to help facilitate safety, to help prevent falls, to provide little gentle reminders, especially in those early stages. So I was just thinking about that environmental piece, because as physicians, how do you bring in people from the outside? Having a teenager, Dr. Lazar, when you said habits, I'm like, that's an excellent idea. So,
Wonderful. So that kind of segues into the next question for you, Amanda. Not environmental, but more communicating. How should I communicate with someone who has dementia? Do you bring them back to reality or make them comfortable in their own reality?
So they're in a different space. So when you think about communicating, it's being where they're at. So identifying yourself in those later stages, high, and stating in intentions. So that way there's no need for interpretation. Being mindful of voice, especially when we live with someone for a really long time. We think that they just get us, right? They just know us. Well, our loved one, is now in a different space. So we have to be very cognizant about our tone, our cadence. How fast are we speaking? Using nonverbals. What is our body doing? And talking about those emotions, because emotions are contagious, and individuals with dementia are really good at getting our emotions. I mean, because like walking into a room, and if you're like irritated because the coffee didn't turn out the way it was supposed to, our loved one with dementia is not going to understand it's the coffee. They're just going to feel that irritation. So knowing your emotional space and setting kind of an intention when you begin communication, breaking down asks into very, very simple steps. So thinking about if you're going to ask your loved one to get dressed, break it right down and provide them, especially in those later stages, with, you have gray pants or purple pants, which pair of pants, helping them, because sometimes the plethora of choices, it's just too much, and then that becomes frustrating for them, and then they're not able to say, I'm frustrated. They just, it's just, it just all of a sudden just bubbles up, and then it becomes behaviors. So giving them simple choices. So being positive, being and enter their world. Don't try to reorient them. Be part of that story and ask them questions. Be curious. Tell me more about the training. Where are we going? And when Dr. Lazar said sometimes there are moments that you can connect. If you're able to enter their world, and then you're on that train with them, and they're like, isn't the view beautiful? And that's that moment where you can really, you're like, yeah, the view is beautiful. So connection is a little bit different with our loved ones with dementia. I think I captured most of the communication techniques. What do you guys?
Any additional insights, Dr. Lazar or Mick?
The question just reminded me of an experience that happened in the community a few years ago, where this fellow was looking for his mother. He's going up and down the halls looking for his mother, and a well-meaning staff member said, well, you're 94 years old, so you see your mother would be 130, so you understand your mother's dead. And what do you think is the only thing that he heard? And so he spent the next 3 hours letting everybody know that he just found out that his mother had died, and there was no connection, because of that. I love your word picture there, Amy, of just joining in, being a part of it. Yeah.
Dr. Lazar?
I completely agree. And the last thing I would say is just a lot of us are excessively task oriented in general,
Yeah.
but particularly when we're dealing with our loved one with dementia. And so if you could try to step away from that orientation, and unless somebody's got a train to catch or a job to get to, which most people in their 70s or 80s don't, does it really matter if they get dressed at 10 instead of 8, or brush their teeth at 8:05 instead of 9? So just try to stay flexible. Keep your mind flexible. If it's not where the person's at, it's unlikely to go well. And if you stay in that task-driven orientation, often we can just generate more upset. And so just backing off and trying again later is the best approach.
Wonderful. So we had talked briefly about some support resources. Dr. Lazar mentioned the Aging Resource Center up at Dartmouth, and we also, I think it was Amanda who mentioned the Alzheimer's Association. Mick, are there any other local or state and national resources for support groups for caregivers?
Yes, there certainly is. And I agree with Dr. Lazar. The Aging Resource Center is phenomenal. And along with that is SASH, which stands for Support and Services at Home. Most of their offices are up in the Burlington area, but they do have one down in White River as well that adds support to that as well. And there is also the resource with the government and in the DALE, the Disabilities, Aging, and Independent Living, where they can point you in the right direction for some support as well. And on the national level, there's a myriad of them. We mentioned the Alzheimer's Association. Positive Approach to Care has YouTube videos all over the place that would help you with understanding how to the best approach. There's also an organization called the Family Caregiver Alliance, and they have all kinds of resources as well. And then not really on target, but they could be a support, is the Upper Valley Community Nurses Project. Lori Harding heads that up, and they may not be able to be the direct support, but they can point you in the right direction to get that kind of support that you need. And your neighbors, they'll be good support as well.
Thank you.
Yeah.
Amanda, Dr. Lazar, any other additional resources that you can think of?
The Dementia Action Alliance is another web-based resource. They are a very proactive group for early disease. So if you have a loved one who's early in the process, you might want to check their information out, trying to optimize well-being at the earlier stage, well, throughout the course of the illness. But the stuff I've come across talks about early disease and how to help a person remain living their full life as long as they possibly can. And also, you know, the VNA and the Bayada Hospice both have resources for caregivers in the community.
Thank you. This next question is for Amanda. With dementia, we see a lot of new normals. Someone perhaps who used to be very clean and hygienic may be that way no longer. Or someone who was very quiet and polite may have exhibit personality changes. We also can see changes in functional abilities, such as being unable to eat with utensils anymore. How can caregivers be fluid in supporting these new normals?
Well, I think it's really and like that everyday assessment of where your loved one is right in the moment, and like, you know, been having the conversation about being flexible. So if, for example, they're not able to eat with utensils, what about finger foods? What about, you know, trying different things, limiting distractions, especially when eating, so that way the individual doesn't have to fight focus. Like, am I focusing on, you know, conversation that's over here, or am I, you know, concentrating on my food? It's really with whatever the caregiver is doing, how can they be flexible in helping their loved one? So some of the information for eating, right? Eating's a big one. Working with individuals with dementia and working in a memory care center, it's like that seems to be like the fight that a lot of people, I can't get my loved one to eat. They won't sit down. They won't, you know, pay attention. Well, really, that was them before. And where they are now, they're a mobile individual who eats on the run, right? Like really, like most of us working around. So how can you help, you know, be with them? Because they may not sit down for that 6-course meal. I mean, if your normal routine was to do that, now here's ham sandwich. Let's walk around safe. Let's, you know, don't choke. and keep on the move. And it's not big meals. It's like little snacky things. And like having it, get a sippy cup. That might be their and make it fun. you don't have to, right? You can design your own sippy cup. You can, get utensils that are easier to handle. Because one of the things that it's that fine, right? That fine motor, and they're not going to tell you, you know what, I'm having difficulties with my fine motor. They're just going to be like, all right, I'm going to opt out. So, and then they don't eat because so being that detective and saying, okay, so let's try this. Let's take a washcloth and duct tape it to the spoon. It's a little bit sensory. It's a little bit chunky. And then, you don't have to go big budget on that. Get creative. And if you have to, toward those end stages, facilitating feeding, this is an event. Eating is love, right? And so to build off eating is love, make sure it's their favorite foods, because if they're not keen on Brussels sprouts, they're not going to be keen on Brussels sprouts when they have dementia. Because those texture foods are, differentiate the food from the plate. Because they're not going to, if everything's orange, okay, there's no food, right? If the plate's orange and the food's orange, and they're not going to be able to say, so make sure that there's definitely there's a difference in color. And so when I was talking about the moment, when you're feeding your loved one, that is definitely a transitional moment, and it's a moment of love. It's a very intimate thing. You're making sure that they get the nutrition that they need, and maintain eye contact. Say you're doing a great job. Don't treat them like a child. Just, here, you're doing great. Would you like another bite? Have a conversation. And just try different times. They may not be a 6 o'clock, it is dinner anymore. And that is going to be a huge adjustment for you. If you're used to that. So that's just so it's the same with different activities, getting dressed, hygiene. It may be a bath day, or it may be a handy wipe day. It depends. And really let them kind of get that feel and let them dictate, because you don't want this, right? I mean, and Mick, I'll hand it off.
I agree with everything you're saying right there. One thing I will add is, if you have a chance to go on to Teepa Snow's YouTube, just put Hand Under Hand. And that has been a phenomenal tool for us, because they're still in control. You have your hand, and I can't describe it here, but you have your hand under their hand, but they're the ones that are actually leading it. And so they're going to be the ones to tell you, I've had enough, by not raising that hand up. The same is true with washing too. You can put that washcloth in their hand and they can do the movement themselves. You're just there to assist them. And it gives them a lot more independence, even in the end stages of this disease. It gives them a certain amount of independence with it, and a little more strength. Amanda, again, you did a great job of picturing all of that.
I agree. And the last thing I'll say is just that don't make it a control struggle. Right. Like if they want to stay in the same sweatshirt for 4 days, who really cares? It becomes a change of lens, right? Of where is the distress lying? And if the distress is with you, the healthy partner, for him staying in the same sweatshirt, that might be more about you, and not that that's a blaming thing, but just that, there's certain things that aren't really about safety, that aren't really about joy, that might just be better shrugged off and try again later.
Mm-hmm.
Thank you. Dr. Lazar, how do I speak with my loved one about surrendering licenses? When is the right time to do that?
So that's one of the most challenging situations we face. I lean on the work of Dr. Bob Santulli, who was a geriatric psychiatrist here for many years before he retired, who used to talk about the grandchildren test. And if you don't feel confident with your grandchildren in the back of the car, should you still be driving around? And unfortunately, many people with dementia deny their deficit and don't really come to terms with the safe driving question until it's too late. I'm thinking of a person recently that I've taken care of who had mild dementia, probably was diagnosed for 2 or 3 years and was still driving and hadn't had any near misses or problems. But the neurologist said it's time to stop driving. And what we forget is that there's other ways that a person with early dementia can get around. Now, and that was pre-COVID, and the Upper Valley has changed a lot since then. But, if you're starting to think about getting rid of the car keys, think about other ways your loved one's going to get around. And it doesn't always have to be you. Maybe there's a neighbor or somebody at your church or somebody who would be just happy to bring them to the grocery store once a week or bring them for a haircut, or, the transportation needs gets filled. So that, and also someone with early dementia can use a bus just fine and needs some coaching and advice on doing that. But, again, to preemptorily disable somebody who's been independent their whole life is what we so often do for fear of safety, right? We do that all the time. So just, I think the answer is don't cut a person's capabilities off too soon. But in terms of driving, if you're a loved one of a person with dementia and you're wondering, you want to ride with the person while they're driving. So if I don't get in the car with my husband very much. And when I do, I'm terrified. And he's 56 and doesn't have dementia. So I think that if there's any concern, ride along with the loved one. And if there seems to be evidence that there's a problem, then you'll want to take it the next step and work on working with your primary care provider to explore that issue. Often making the provider responsible takes it out of your hands. So you're not the bad guy. The provider is the bad guy. And better for them to be mad at the doctor than to be mad at you. So I don't know. I talked a lot. Is that about what you're looking for?
Yeah, that's great. I don't know if Mick or Amanda has anything additional to add to that.
Not really. It's good to have that communication for the doctor to have that communication with the family ahead of time, so you can get it all scripted out right, so that there's no illusion of it being your fault. I agree. If you can channel that frustration at someone that's not in the immediate family, that makes a big difference.
Thank you.
And just from a practical standpoint, sorry, I'll say one last thing. Sometimes rather than saying you can't drive anymore, you have dementia, it's much easier to say this is further on in the disease, but it's much easier to say the car's in the shop or your daughter needs the car, or, so just to take it out of sight, out of mind. Sometimes that's worked very well for some of my patients with further on down the line disease.
Thank you. This last question is for Dr. Lazar, and then open it to everyone else. Is it important to complete an advanced directive or POLST/COLST form with my loved one? What might happen if these forms are not completed?
Well, thank you so much for asking that question. I honestly believe that this is one of the most important things we can do for our loved one with dementia, with our loved one with dementia, and then for our loved one with dementia. This is a long conversation. I'll try to be brief. But, the medical universe is designed to keep people alive, period. That's what we do, right? When a person is in the advanced stages of dementia, there becomes a lot of questions about benefit versus harm for any number of interventions that the medical world would be perfectly happy to give you, right? You need a valve replacement, you need treatment for your cancer, you need your knee replaced, we're not great as a medical universe, at recognizing the individual variability in older adults, and particularly older adults with dementia. And when the hospital becomes a place of potential harm, much more than a place of potential benefit. So these are people obviously with more moderate to later stages of illness. And so an advanced directive helps you to put a lens on that says, what would my loved one really want? And how am I most likely to get that? And so an advanced directive basically does a few things. It defines who would be the decision maker for your person if they're unable to make their own medical decisions. We call that a power of attorney. It's that's a complicated question, but in terms of advanced directives, generally there's a power of attorney who is generally a spouse or a child, sometimes a friend or neighbor for somebody who's on their own. That's a trusted, loved person who knows the person's values and goals. So that part of it is important, very important to get done upstream. Because if it's not done upstream, then you can run into problems of needing guardianship to make decisions when the disease has gone on far enough that the person's not really able to say for themselves who they would want. So that's one thing. The other thing is just to think about limits on aggressive medical care. So I often help people distinguish between resuscitation and treatment. Resuscitation is after a person stopped breathing and their heart has stopped. We have two choices. We can either allow a natural death for that person, which in many ways is a blessing, or we can try to bring that person back to health. And unfortunately, when people are in their 70s and 80s with lots of medical problems, the odds of them being able to return to who they are now are very, very low, sometimes zero. And so by saying you're going to resuscitate a person who's basically died, you're opening the door for sometimes increased suffering. And those are questions that are individual. Everyone needs to think about it for themselves. I'm not trying to be proscriptive, but it's an important distinction. And by not resuscitating, you're not saying don't treat. Those are two different buckets. And so there's all kinds of treatments that you can still have if you're DNR. And I treat people every day who are DNR, but still want to go to the hospital and have IV fluids or IV antibiotics or a treatment for a reversible problem. And so that distinction is very important. And when you're talking about the P or the COLST, those are just an acronym for provider order for life-sustaining treatment or clinician order for life-sustaining treatment. The two states have a different wording for that. But this is a clinical order. I went to a talk one time where somebody said, I'll stop talking after this too, I know I'm going on too long, but the presenter said, we plan more for a vacation in America. This is pre-COVID. We plan more for going on vacation than we plan for what we want at the end of our life. And I just thought that was a brilliant analogy because she's right? We all think and plan and get ready, but about the end of our life, we don't want to talk about it. We don't want to think about it. So I think this is changing. I think we're moving in the right direction, but I would encourage people, especially if you're facing the diagnosis of dementia for yourself or a loved one, sit and talk about it, Thanksgiving's coming up, not that people are going to be together this year, but talk about it with your family and just make clear, okay, if you're somebody that absolutely wants to be resuscitated and wants full court press until you die, let them know that so that people know what your preferences are. So sorry, I'll stop talking now.
Thank you. Amanda or Mick, do you have any additional thoughts on that?
And that is that Dr. Santulli had put together a COLST of sort, advanced directives of sorts for those with dementia, which goes specifically into, do I want to be fed, and other behaviors that come up with the end. I think it was brilliant, and it's accessible through the Aging Resource Center.
Amanda, did you have anything additional?
I think it's just having that honest conversation, because you're your power of attorney really represents you. So if you choose someone who, so like my husband and I have discussions, and he's like, "You get everything," and I'm like, I don't know if I want everything if I have X, Y, and Z. so it's really making a really good choice in the person, who's that trusted individual. Are they going to represent you? Are they going to be your voice for when you have none? So choosing someone who will really, make those hard decisions that sometimes individuals who are closer. To give you an update, my husband and I have had many discussions, and he's willing to represent me fully. So.
Well, thank you all so much. I don't know if you have anything additional that you would like to say before we sign off here. Feel free if there's something else that you want to say about caring for someone with dementia.
Just a little plug, if you hear about a business in the spring called the AD Partnership, that is my wife and I starting up a business specifically for those with dementia. So, yay.
Can I just say one last thing? Is just to, feel free to reach out to people around you, and the medical community is part of that, but all the rest of the people around you are also part of that. And it's not a death sentence. It's something that people live with for many, many years, and living people's best lives is certainly possible, and it takes a village to make that happen. And we're all part of that work, the four of us here, but also just there's tons of people in this community who love and care for people with dementia, and you're not alone.
Well, thank you so much, Dr. Lazar, Amanda, and Mick. We really appreciate you joining us today to talk about dementia, and we look forward to hearing from you again.